So with that, it's my privilege to introduce Dr. Wendy Spearman, who's a professor at the University of Cape Town, who will be talking about the new WHO guidelines.
So good morning, everyone. So I'm going to really be talking about these guidelines, which we hope is going to really change how people see hepatitis B and really empower them to actually manage people living with hepatitis B. So I think very importantly to remember, despite our availability of diagnostics, preventative vaccines, and effective antiviral therapy, hepatitis B remains a major public health burden. And as we've heard, in 2022, WHO estimated that about 254 million people were living with hepatitis B, and there was just over 1 million deaths. And as we've heard, only 13 had been diagnosed and less than 3% treated. So globally, we're off track to meet those WHO 2030 elimination guidelines, but particularly in low and middle income countries, which account for the highest burden of hepatitis B. So we see in Africa, 66 million, Southeast Asia, 61, and Western Pacific, 97 million. So more than 2/3 of HCC and cirrhosis cases related to hepatitis B actually occur within these regions. So most of this global burden of chronic hepatitis B is really attributed to mother-to-child transmission, either at the time of or shortly after birth, leading to very high rates of chronicity. Very importantly, we need to realize that if we're going to actually address this, we need to rapidly scale up testing and treatment to reach these good goals. And as you can see, really globally, we're running into problems in terms of diagnosis and accessing treatment. So that requires really radical simplification of diagnostic approaches, treatment criteria, and service delivery models, particularly addressing integration, if we're really going to overcome these barriers to accessing therapy. And then once again, this out-of-pocket expenditure. You can see in the Africa region and Western Pacific, in terms of hepatitis B diagnostics, more than 50% is actually out-of-pocket. And then we see this wide discrepancy of the cost of hepatitis B viral testing. So in Rwanda, just over $9, but you can see in Indonesia between $28 and $62. So there's this wide discrepancy and inequity enabling us to actually monitor appropriately long-term. So as we know, all guidelines actually base their treatment decisions on incorporating DNA and ALT levels. They provide guidance on biopsy assessment for fibrosis, and they recommend treatment based on the different phases of chronic hepatitis B, but taking into factors such as age, family history of cirrhosis, and liver cancer. And they all really agree on the goals of therapy. You want to improve quality of life and survival by preventing progression of disease to cirrhosis and end-stage liver disease, liver cancer, and death. But I think we need to remember that guidelines are guidelines. They need to be relevant to the appropriate region. So what was the real aim of these WHO updated guidelines? It really was to improve access to therapy. So we provided 4 options to meet treatment eligibility, which would then capture about 50% of individuals with hepatitis B compared to the previous 8 to 15%. There were new APRI criteria, which is the non-invasive testing to assess fibrosis, looking at the AST to platelet ratio, and importantly, alternative viral regimens. If you had only access to dual therapy, particularly through HIV programs, you could initiate tenofovir plus lamivudine or tenofovir plus emtricitabine. And then importantly, expanding the access of antiviral prophylaxis to surface antigen-positive pregnant women. So if you did not have access to DNA or e-antigen positivity, you could actually prescribe that tenofovir and prevent mother-to-child transmission. Importantly, encouraging use of point-of-care surface antigen testing, as well as hepatitis B DNA quantification assays, and then the reflex hepatitis D co-infection testing, which we know results in more aggressive disease. So what are the recommendations? So all adults and adolescents should be treated, and this includes pregnant women, women of childbearing age. So top of the list really is identifying those with advanced fibrosis or cirrhosis, because you mustn't miss these individuals. And that's based on an APRI score greater than 0.5, or liver stiffness greater than 7, or cirrhosis based on clinical criteria, but remembering by that stage you would have missed the boat with an APRI score greater than 1, or liver stiffness greater than 12.5. Or if an ALT greater, HBV DNA greater than 2,000, with an ALT upper limit of normal, you can treat. and that captures another 20 to 35% of patients. But then very importantly to remember, if you have presence of co-infections, if you have family history of cirrhosis or HCC, immunosuppression, or extrahepatic manifestations, then you treat regardless what the ALT level is, regardless what the APRI, and you can enable you to initiate therapy, even at primary care level, but you will refer upwards. And I think very importantly, if you have no access to that DNA monitoring, which is often a barrier, and we know that in many areas within Africa and across the world, that access to DNA is not costly, is very costly and not actually affordable. And so here, if you have a surface antigen positive, an ALT positive on more than 2 occasions over a 6 to 12-month period, you can actually treat. So you can see wherever you are, you have the ability to treat, and then you really need to decide, can you remain at primary community care level, or do you need to refer upwards? So we know treatment coverage, if we're going to actually achieve these goals of the 2030 elimination goals, we need to actually achieve 80% of individuals being treated. And I think very importantly, these new guidelines will have a positive impact of 2/3 of the countries will actually bear most of the burden of disease, as can be seen in this slide. So we're really looking at a public health approach, which is aimed at the program managers of low and middle income countries and frontline clinicians, which are often not specialists. So it's not an individualized approach. The members of the WHO group really came from 6 of the 6 WHO regions, but importantly, 50% were working in the low and middle income countries. And so we aim to not only increase access to care, but importantly, retain people in care and link them to long-term care. So in terms of simplification of care, you need simplified treatment algorithms. And so understanding that complex natural history of chronic hepatitis B with the 4 phases, which was associated with very specific virological profiles and difficult clinical prognosis, was often a major barrier to initiating antiviral therapy. Also, the level of monitoring, particularly hepatitis B, viral loads, liver stiffness measurements using transelastography, is really very limited. And so we're now able to actually initiate treatment, and have ongoing treatment without access to these more costly procedures. So diagnosis and monitoring will depend on the clinical setting and the availability of resources. Importantly, we can now diagnose fibrosis and cirrhosis based on that non-invasive test, the APRI score. And importantly, this is very important because hepatitis B actually is the major cause of cirrhosis and liver cancer throughout Africa and in many of the low and middle income countries. The recommendation of point-of-care testing and DNA quantification is important. I think we need to remember that in terms of the gene expert, we have in Africa alone more than 7,000 Cephei platforms to measure HIV and hepatitis B and HIV and TB. So this is very well resourced within the primary care, but we need to expand this to hepatitis B. The viral load, as I said, is no longer a barrier. And very importantly, I think these guidelines take away that really confusing gray or indeterminate areas where the ALT levels vary, the DNA levels vary. So you have very defined recommendations in terms of DNA greater than 2,000 and an ALT just above the upper limit of normal. So remember, for men, that should be 30, and for women, 19. Lowering the cutoff of that DNA, I think, is important. We know from systemic reviews there's a dose-response curve in terms of the baseline DNA and the incidence rates of HCC with cirrhosis and liver-related deaths. But this is the first time from the WHO guidelines that we learned about the number needed to treat to prevent 1 case of liver cancer. So if you look at the DNA being greater than 2,000, you need to treat 59 to prevent 1 case of cancer. And in terms of cirrhosis, you need to treat 21. So we have now evidence of how many you need to treat, and shows that actually this is actually cost-effective. Lowering that APRI score to diagnosing advanced fibrosis, I think, has been particularly relevant in terms of Africa. We know that the previous guidelines from WHO of greater than 2 to diagnose cirrhosis was problematic. In Ethiopia, this actually missed 50% of individuals who had cirrhosis. But more concerningly, of those who were diagnosed cirrhosis, 50% already were decompensated. So these new APRI guidelines actually really align much better with HepSonet group, which was a systematic review of individual patient data meta-analysis, which looked at nearly 3,500 individuals from Africa and showed a more appropriate APRI score was 0.65. So we're now much closer to that. And then importantly, prevention of mother-to-child prophylaxis for terms of tenofovir and that birth dose vaccine. And so that is really key to actually elimination within low and middle income countries. We always remember that highly viremic individuals, if they're E antigen positive, greater than 200,000, will get treatment. But this has been a major barrier. And so we've now overcome that. You will treat if there's no access to DNA quantification or e-antigen testing, just based on that surface antigen test. But remember, this should not take the place of the birth dose vaccine. And importantly, pregnant women must be referred for ongoing treatment and the need for ongoing treatment or whether they can stop. But remember, this is an opportunity to break cycles of infection, to screen partners and siblings and children for hepatitis B, link them to care or vaccinate them. And then lastly, the reflex hepatitis D co-infection testing. I think this is one thing that's really is problematic. It depends on resources. Ideally, all surface antigen positive individuals should be tested. But importantly, I think we need to be pragmatic and look at those at increased risk of co-infection, particularly those countries which are highly prevalent, such as Mongolia, Moldova, and within Africa, the Western and Central Africa. But there are implications, the cost of the diagnostics, and really within Africa, bulevirtide is not available. So this is really difficult to implement in our region. So in summary, the WHO guidelines take a public health approach to the management of hepatitis B. They're really aimed at expanding the criteria for the initiation and treatment and promoting of treatment, particularly in low and middle income countries. I think it does help to demystify management of hepatitis B. Initiation of tenofovir UNASI is no longer dependent on that complex natural history of hepatitis B, understanding those 4 phases of chronic hepatitis B, which hepatologists love. Access to DNA quantification is no longer a barrier to initiation of therapy. And I think we need to really promote the point-of-care diagnostics and the APRI score for assessing fibrosis, because this enables treatment to be initiated at any stage and then merely decide, do you refer upwards? But unfortunately, successful implementation is going to require integration and breaking down of silos of healthcare services and with appropriate allocation, I think, of domestic resources. Thank you very much.